Salam alaikum, dear colleagues and friends. It's a great honor for me to talk about aspects of diabetes prevention. The title says new challenges from the IDF, but this is not true, I must say. It's a challenge to all of us. It's a challenge we have to face in our daily work. And I would like to go through with you through some new aspects of diabetes prevention, which may be applicable to you in your daily practice from tomorrow, from the next day you are in office. About myself, I already spoke a few minutes ago. I'm the current president-elect of the International Diabetes Federation, and this means that I will use all my energy to invest into prevention of diabetes, but also addressing all the different facets of diabetes care. And acting for IDF or on behalf of IDF means for me that we have to address the need of our patients. Looking into these different phases of diabetes patients worldwide, we have to address this need, except that this is the need of people with diabetes varies a lot, but our obligation is to address this in an honest and effective manner. As long as a father has to decide buying insulin for the son or the food for the family this day, we have not fulfilled our task. And this is what is driving me for IDF. But especially this means, in my eyes, prevention, establishing prevention and preventive activities for diabetes on all levels of healthcare, including public health, including community health, but also using digitalization to transport prevention basically to the people at increased risk, and do this on behalf of IDF, and using IDF as a global NGO who has a potential to establish this on a global scale. But the situation is a challenge. Here you see 540 people from Facebook, all the red one on a global scale to develop diabetes, but there's also a lot of hope, and these are the green ones. The green ones have the same, let's say, wrong lifestyle, but they never develop diabetes. The green ones have some secret in them preventing diabetes from developing. And there's a lot of research going on to differentiate one from the another. And if we find this, we may have a physiological answer of effective prevention. It may be physiology, behavior, genetics, epigenetics, many facets play a role. But diabetes has an aspect, a global aspect, so global health is something we have to consider, we have to understand. Here you see the different regions in the world and how the prevalence of diabetes is increasing. You see in the European environment, there is a stable prevalence of diabetes because we are high already. But if we go into other regions in Africa or in Asia, you see there's an enormous increase of prevalence of diabetes we have to expect in the future. And this means we have to understand what are the health determinants if we are talking about diabetes. And this slide shows where the increase in prevalence is coming from. And the blue triangle is the increase of prevalence due to increase of population. But the yellow and the red one, this is attributable to the change of lifestyle, the change of environment, the change of living condition, the urbanization. And these are aspects we have to address on behalf of IDF. But there are also more. There is a strong coincidence with the increase in prevalence of diabetes and, for example, climate, here represented with air pollution. I will not say that air pollution is making you getting diabetes, but it's becoming a relevant, important risk factors, especially if you talk about aspects like urbanization. And if we look at the risk factors who are responsible for premature deaths, then we see many of the risk factors are related to diabetes, and many of the risk factors are also related to diabetes in a climate change situation. So this is something we often ask, or our politicians and policymakers do not have on the agenda. They say, oh, diabetes, it's a disease which is You may treat, and it's not so urgent. But all the risk factors related to diabetes, all the aspects of diabetes, of the disease diabetes, are related to morbidity and mortality of the population. And this is something we should highlight in the future better. But this may lead us to prevention, which is the only way to address this. These two numbers, in my eyes, are effective prevention. If we would walk 10,000 steps from the age of 22, we would not contract any chronic disease, including diabetes. But it's actually getting better. If the patient has diabetes and is walking only 1,000 steps more than he normally does, it lowers the postprandial blood sugar by 1.5 millimole. This is twice as much as 1,000 milligram metformin are doing. What is the average European walking? 2,700 steps. We are a very lazy species, and it should be our goal to improve this. But look, in many regions in the world, there are actually physical activity, daily physical activity is significantly less, especially in the Gulf states, in the Arab states. So we have to think about how can we improve this. If I ask the other way around, how many hours per day we are physically inactive, this is the answer. We are a lazy species, and this is making us sick. The most effective anti-diabetic intervention is not in our brain as diabetologists, it's not in our prescription as diabetologists, it's in the muscle of our patient, if we would be able to activate this muscle. If we would be able to activate our own muscles to be a good example for our patient. This leads us to understand pathophysiology better. The development of the glucose sensor have been a breakthrough in the diabetes care sector. And here you see a young woman with a high normal A1C, and the green arrows mean she's eating something, and the purple line is the glucose over 24 hours. And we see there's no elevation. This is an example of someone who's really healthy. She's very insulin sensitive. And even if she's eating a lot of carbs, there's no elevation, no change in blood sugar, because it's a very effective glucose metabolism. In comparison, her father, it's also truly her father. And you see here is actually having a better A1C than the daughter, but it's obvious there's a totally different curve. Yeah, with the fluctuation of glucose, this was maybe breakfast, this was lunch, then it's going down. There was no physical activity, no drug taken. Today we know that this fluctuation are a very, very strong risk factor for mortality and morbidity of our patients. So there are very strong cardiovascular risk factors, very strong risk factor for premature death and worsening of outcome. The difference between daughter and the father is very insulin resistant. He may need 80% of the insulin to regulate blood sugar. In comparison, the daughter needs only 1% of the insulin to regulate blood sugar because of her insulin sensitivity. But this father, he is actually maybe 3 years away from contracting diabetes. So it would be exactly the right moment to act for prevention, but we don't find them. We cannot give a sensor for screening to everyone. But the consequence of this understanding, this new understanding, is that our goals in managing diabetes and managing prevention of diabetes is this: lowering the high and the low high and low glucose value, so lowering the amplitude of glucose excursion. So imagine you have two people with an A1C of 7, one has low fluctuation, the other one has big fluctuation. The one with the big fluctuation will die because of a stroke and a heart attack. So by reducing these fluctuations, we prevent comorbidities. And the most effective way to do is a lifestyle change. Here you see the development of hyperglycemia and diabetes, the development of insulin resistance over years, pro-insulin resistance. All this is triggered by the visceral obesity and transmitted by the release of free fatty acids out of the visceral fat. But now a new player is on the game, it's the hepatic fat. And since about 5, 6, 7 years, we know that the liver fat plays an important role in the progression of diabetes. And you see, it's actually before a severe insulin resistance develops, already liver fat develops, and then continuously the patient is gaining liver fat. And the consequence of understanding diabetes pathophysiology is we have to get the visceral fat away and we have to get the hepatic fat away to really prevent diabetes from developing. And if I ask you now, what is the best way to get visceral fat away? The answer is physical activity, physical activity, physical activity. Because by using your muscles, you enable that the free fatty acids are metabolized in the muscle and in the body, and by this visceral fat is the amount is reducing. But how to get the hepatic fat away? Because understanding if you have 120 grams of hepatic fat, you become a non-responder to physical activity. You become a non-responder to many diabetes drugs. So we have to get the hepatic fat away first to make the physical activity effective to reduce visceral fat. And the only way to get hepatic fat away is fasting. If you fast without eating any kilocalorie, so that means water diet for 2 weeks, that means not eating anything for 2 weeks except tea or water, you abolish totally your liver fat. So you make your liver fat totally disappearing. And in my eyes, this is one of the very, very effective way of preventing diabetes. Here diabetes starts, here we start treating diabetes. So we come far too late to really prevent diabetes in the medical system. We have to act in this red paradigm to get the patient, to get the person at risk, to make a difference. And this means we have to address the interplay between hepatic fat, insulin resistance, and visceral obesity. These two fat compartments making you getting diabetes. This is subcutaneous obesity. This is the visceral fat depot. And why is the visceral fat so dangerous? Because we know that more than 800 peptide hormones are released out of the visceral fat. And they act on the whole body. They make depression, dementia, insulin resistance, diabetes, hypertension. And as less fat you have, as less of these hormones you have. And here's an example of the insulin signal transduction cascade, and all the red substances come out of the visceral fat and block this process. This is insulin resistance. And this is a common soil for many other diseases as well. And here you see the comparison of people without liver fat and with liver fat, and NAFLD is a synonym for this. And then the separation between obese and non-obese, and here is insulin resistance. And you see the obese person without liver fat has a better insulin resistance than the slim person, but having liver fat. So liver fat is a trigger for diabetes development, but the opposite, if we would be able to remove the fat out of the liver, and by this also removing the fat out of the pancreas, then we may restore better cell function, and this may lead to a remission of diabetes. So in my eyes, I think there's a good future that fasting, therapeutic fasting, can lead to a remission of diabetes, a remission of type 2 diabetes. Of course, we know prevention of diabetes is effective. Here you see the summary of the study, lifestyle change in more than 50%. Also, drugs have an effect, but mostly the effect of the drug is gone if you stop the drug. These are the 5 core goals for diabetes prevention. And if you have 100 people and over the 1 year, analyze how many of these goals are implemented. If you don't implement any of the goals, 8 out of 100 gets diabetes. If you implement all 5, none gets diabetes. So this is a strong argument for a healthy lifestyle to be effective in diabetes prevention. And all these prevention studies, if you look again into the pathophysiology, what have they achieved? And the European and the American study has achieved lowering visceral obesity, lowering insulin resistance. The Asian studies were actually physiologically a bit better in achieving this, but the pathophysiology tells us what is effective in diabetes prevention. But we also have to understand how we are thinking. And here you see 380,000 patient years on the slides, and it's analyzed if you drink 1 soft drink per day over a year, what it does with diabetes risk. Water is not increasing diabetes risk, is shown here. Orange juice, industrialized orange juice, 40% like a Coke. but a Diet Coke makes 60% diabetes risk increase. Why? And the answer is the artificial sweetener in the soft drinks, they change the microbiome. And the change in microbiome, there are 14 different germs in the gut. And this bacteria produce saturated fatty acids, which are detrimental for our human metabolism. And these fatty acids are incorporated through the gut, and they land in the liver, and they make a gain in liver fat. So you exercise, you have a healthy microbiome, and by eating or drinking too much artificial sweetener, you change this microbiome, and you become a non-responder of physical activity. And this is a disaster in my eyes if you are talking about diabetes. But we have to also understand how our patients are changing behavior, or actually all of us are changing behavior. If we talk about diabetes and obesity, we as physicians are out of the game for the lifestyle change of the patient, because the peer group of the patients, family, other patients, friends, even friends in social networks, are more important for the lifestyle. And the only trigger for a successful lifestyle change is quality of life. And the patient wants to recognize within 2 days that quality of life is improving. This may work. Here are techniques shown which you can use, like motivational interviewing, reflective listening, change talk, to help the patient to move through different changes of lifestyle change. You can initiate this, but the most successful environment is the environment, the peer environment of the patient to implement this. We had the chance to develop standards for diabetes prevention with the Diabetes Prevention Toolkit as part of a large European project. This toolkit is a toolkit, a cookbook for successful diabetes prevention, addressing all questions which are needed for diabetes prevention practice. And this goes along with training programs for prevention managers, and also examples of educational programs for diabetes prevention, which are available in many languages in addressing different cultural aspects. If you are interested in getting access to it and to distributing in your country, always write an email to me and we can enable this. But we have to target the need of our patients. And here's an example shown. Imagine there's a 3-dimensional room looking for morbidity, interests of the patient, and readiness to change lifestyle. And we combine this with digital tools which are available today and call this competence toolbox. So analyze the behavior and the need of the patient, use digital information with this, call this risk stratification. And then imagine you have 100 different interventions for diabetes prevention, analyzing this information as a kind of assessment, and this can be automated on a smartphone, will tell you what interventions will be most effective for this patient for diabetes prevention. In my eyes, this is the future and will be supported by smart health. We did an extensive review with more than 3,000 articles showing what kind of digital intervention is able to lower A1C. And at the end, it's everything what is addressing the daily routine of our patient, and its individualization and intensity and frequency of contacts. And we as physicians should do this. Our guideline from 2019 already telling us we should knowledgeable and use apps for diabetes prevention and care. And this slide shows you how effective digital tools, young digital tools, can be in comparison to our oral anti-diabetic drugs in lowering A1C. And how can an app on a smartphone lower A1C, as it is shown here? And my answer is, we are in the pocket of our patients. We never have been so close to our patient than being in the pocket. And if modern diabetes prevention may look like this, why not? I think if we are so close to the people at risk and our patient, we should think about modern digital strategies for diabetes prevention and care. And we will gain a lot of success in reaching the patient, because we are in their daily routine and we are able to help them in their daily routine to change lifestyle and prevent diabetes. Here are examples from Germany for apps which are licensed and the physician can prescribe for diabetes prevention. It's about, and also diabetes care, and most of them are about behavior change. And some of them work with artificial intelligence. This is Alfred, where you make photos and you get a feedback, and not a blaming feedback, but a motivational feedback about changing diet. There are other apps using the sensors and doing nutritional coaching by the sensor with programs based on cognitive behavior change therapy. And here's a very modern development also using the sensors. And this is basically the diabetologist out of the pocket, because they analyze the curve and they make precise recommendation regarding nutrition, physical activity, and also treatment to change the curve and to prevent diabetes. At the end, eating less is healthy. Eating less reduces type 2 diabetes risk, and it's good for your overall cardiovascular disease and metabolic disease. The medical dimension of fasting, and that means 2 weeks of fasting and not eating any kilocalorie, is in my eyes the fastest health gain we can achieve. Nothing else can achieve so much increase in health than not eating anything for 2 weeks, only drinking water. You lose a lot of weight, and most of them is visceral fat, but you abolish totally your liver fat and you reset the microbiome. And I think this could be a good option for our patients with type 2 diabetes. Here, an example, what is achievable: 10.5 kilogram weight loss in 2 weeks. And an example that, because you are running in ketosis while you are fasting with a 0 kilocalorie diet, and this ketosis leads you to burn ketone bodies, and the ketone bodies are made out of the fat, primarily liver and visceral fat, and by this you are losing this. And this is of benefit for diabetes prevention. And we normalize glycemia. This is an AGP throughout fasting, and you see this looks very similar to the early AGP or the early glucose curve I have shown you from this young women with a totally flat glucose curve. So fasting will reach this. And in my eyes, this is effective prevention of diabetes. Stop eating, empty your gut, drink 4 to 5 liters of water or tea per day. First and second day are challenging, third and fourth day are difficult, and then it will be great. And you have to be physically active. If you're not physically active, muscle is broken down. If you're physically active, this is prevented. And it's important how to break fasting. And you have to do it in a standardized way with 600, 800, 1000, 1200 kilocalories in the first 4 days after breaking. Is this enough? Of course not. 10,000 steps a day is prevention of diabetes. Using a pedometer helps you, but don't ask your physician. Here are 31 diabetologists on a German diabetes meeting on this slide. One is using the stairs, all the others the escalator, airport in Doha, airport in Munich, airport in Dammam in Saudi Arabia. Don't forget the 10,000 steps, and let's work together with all our enthusiasm and passion to prevent diabetes and more precisely to walk away from diabetes. Shukran. Thank you very much for your attention.